All right, so let's take a break and come back for EKG basics. I thought that was EKG basics. What the heck? All right, so EKG basics, the boxes. All right, so now we're going to go into the actual boxes and what they mean, and how to calculate a heart rate, and then we'll talk about the intervals and what those are important for. We kind of talk about some of them, like QT interval is pretty important. PR intervals are becoming important. We talk about about AV blocks. So we'll talk about these guys, and then we'll dive into the actual rhythms themselves, where again, you have to know the basics, just like a disease process. What causes it? What are the symptoms of it? What are the treatment of it? What are diagnostic tests I might do for it? What are the complications of that disease process, or EKG, like death for asystole is a complication, right? And then what are the nurse interventions? What should I do if someone has this rhythm? What should I teach someone? What should I, I'm not going to reiterate myself and say what are the side effects, because teach the side effects of this medication, okay, right? All right, so the EKG boxes, all right? So the little boxes are worth how much? 0. Depends. Well, it depends. Depends what direction you're going. If you're going north-south, meaning up and down, it's 1 little millivolt. If you're going left and right, that is in seconds or milliseconds. If you look at a 12-lead EKG, or most physicians are trained in milliseconds. You just got to be able to interchange between that sometimes, right? But going left and right is 0.04, right? I said 1 millivolts. It's 0.1 millivolts, right? So if you're going left and right, that's 0.04 seconds. So 5 little boxes is what? 0.2. 0.04 times 5 little boxes is equal to 0.2. All right. So that's the nice thing about that, is that when you have those 5 small boxes, the lines get a little bit darker. So they're a little bit darker after every 5 boxes, right? Sometimes you have to, cross your eyes like a magic eye, but when it's a good printout, it's HD, UHD, you can actually see the thicker line, and between each thicker line is 0.2, right? If you have 5 thick lines, that's 0.2 times 5, which is 1 second, right? So the big boxes can give you a lot of good information, because we said 5 small boxes inside of 1 big box. Well, we measure PR intervals, right? If it's bigger than 1 big box, you've got an AV block. You have when we talk about AV blocks, they usually always have a prolonged PR interval. So if it's bigger than 1 box, that's a quick clue that you have a AV block on your hands, right? And then what else? The QRS, we're not going to really spend too much time on the QRS. All you have to know is if it's prolonged, it's a bundle branch block, not an AV block, but a bundle branch block. But we're not going to differ, and you won't differ them in other semesters either, whether it's a left or right bundle branch block. If in clinical you want to know and you want to come to me and ask, we can go over it, but it's not important. All you have to know is that if it's wide, it could be a bundle branch block. Okay. Yeah, the QRS. Yeah, the PR is wide. It's usually a AV block. And then the QT interval. So the QT interval tells us how long it takes the heart to repolarize, and if it's getting longer and longer and longer, they're at risk for what lethal rhythm? Torsades, and we'll talk more about torsades, right? So another thing you want to notice, that all of these are measured what? Isoelectric to isoelectric, isoelectric to isoelectric, right? So they're always isoelectric. It's not any kind of dip or divot that you're measuring these from. It's always from straight line to straight line, okay? All right, what else about the boxes? So going up and down is in millivolts, going left and right is in seconds. That's really what we're going to be dealing with. We're not going to be dealing with, oh, the QRS is 5 millivolts. It's not going to be important to us right now. When you study 12 leads after nursing school, then yeah, that you can study that and realize someone has left ventricular hypertrophy or right ventricular hypertrophy. But right now you're focused on little boxes, and all this you learned in physiology, all the little small boxes and millivolts and intervals and such, right? But we're just now going to apply them. If they're increased, what does that mean? And what am I going to do about it? If it's the QT is prolonged, what am I going to do about it? Okay, so again, going up and down is 0.1 millivolts. 1 small box left and right is is in seconds, right? So PR, QRS, what's RR? It's respiratory rate. What the heck is that? What the heck is an RR? That's how you calculate your heart rate. So R to R is from R wave to R wave. So, well, that's not isoelectric. Well, you could do here to here if you wanted to. All you're doing is looking for what the between the different QRS complexes. The R to R is easier to spot, though. So you look from one peak to the next peak. What's the R to R interval? And when you have the R to R interval, that's seconds. And now you can figure out beats per minute by using dimensional analysis, right? So if I know that's R to R is this many seconds and how many beats per minute, you could figure that out, right? So, but there's an easier shortcut method that we'll talk about, okay? So PR, QRS, R to R interval is important. QT interval is important, okay? And then we talk about the small box and large box sizes. And then strips are most commonly 6 seconds. When we show you a strip, it's usually 6 seconds. And you can assume on the test also that if I give you a strip and like it's an irregular rhythm, there's a way to calculate the heart rate. You can say, oh, is this 5.5 seconds or 6 seconds? It's a 6-second strip, right? But in real life, if you're looking at a readout, you use little hash marks right there. And they denote 3 seconds of time, right? And so that you can, if you have 2 of those together, you have, of course, 6 seconds. So just an FYI when you're looking at a strip in real life, okay? And if you're looking at an irregular rhythm, you need 6 seconds to calculate the heart rate, right? Because you estimate the heart rate based on how many R waves there are in that strip, okay? You need 6 seconds to do the estimation correctly, okay? And then the regular rhythms, though, you can't count, if you can't count the number of R waves in a 6-second strip and multiply by 10, which is the shortcut for the irregular rhythms, you have to calculate the R to R interval, or you can use the 300 method, which is a cool workout back in the early 2000s, right? But the 300 method is when you get to memorize the sequence of numbers. You can not memorize it and do the dimensional analysis every time, but you're going to be hampering yourself. So there is a little quick shortcut to this. So we'll describe these 2 methods of calculating the heart rate. Okay, so down in the bottom right corner is those for the math nerds, right? If you really want to figure out what the beat to beat second is and then how many beats per minute and multiply this and multiply that, that will get you to the right answer. Or you could do that 5 times. Do the math 5 times. It's like, well, how much is it for one big box? Well, if the R to R for one big box is 0.20, right? And I do all the math, I get 300. My heart rate's 300 beats per minute if my R wave was right there. If my heart rate was that fast, it's 300 beats per minute, right? Now, if it was the next big box, I throw the numbers in there, 0.4 seconds, right? 0.40 seconds, not 0.04. And then I put all the math in, I get 150. Do it in the next box, I get 100, right? The next box, 75. Next box, 60. Why is this important? Because you could just line up a QRS complex with a line, right? The solid line right there, right? And then go out and you can easily see if it's a tachycardia because it's greater than 100 or it's a bradycardia, it's less than 60. You can see where it falls in that space. So I asked ChatGPT for a song that lines up these numbers. They had poor results. But anyways, you could it was like doing like Frere Jacques and such. Either way, 300, 150, the 100, and then if your next QRS complex was less than 100 or was within that space, you have a tachycardia in your hands, right? Guaranteed. Now, if its QRS complex followed after that, it was either a sinus rhythm a regular rhythm or bradycardia. Okay, so I mean, there's other methods. There's the 1500 and 300 division method where you count the number of small boxes and then divide it by 1500. That takes a long time. Also, you can take 300. All the math checks out over here if you do 300 and 1500. But again, this is a shortcut, so you just memorize those numbers and you'll get to the right answer every time. So we have some little practice questions that will make this make sense, right? All right, so there's a 10x method. So you have the 300 method and the 10x method. Only one of these can be used for regular rhythms, and that's the 300 method. For irregular rhythms, you have to use the 10x method, which is where you just count the number of complexes, PVCs included, R waves included, all those things you count inside of a 6-second strip, and that you multiply by 10, that is your heart rate. Okay, so first in the bottom left there, you see the 6 seconds right there. So if this is like in real life, but on the test, again, I would probably give you just the 6-second strip. I would cut off those other complexes, right? But if we look at those, how many complexes do we got right there in the bottom left corner between that 6 seconds in that 6 seconds as marked there? 10. All All right, so 10 times 10 is 100. The heart rate's 100. Okay, it's like, why does that not work for regular rhythms? It just doesn't, because there's variability there. Okay, so there's a quick way to figure out your heart rate. Okay, so the first thing to note if you're calculating someone's heart rate is it irregular or regular, right? If it's irregular, I just count the number of complexes and multiply by 10, right, in 6 seconds, not like 20 seconds, right? And if it was regular, then I have to look at I could measure the number of small boxes and divide and such, but if I memorize the 300, 150, 100, 75 deal, that's going to get me the heart rate approximated. Okay? All right. Do you want to separate in groups, or do you want to do this one together? All right, so this one together. The other ones we'll do in groups, like the sinus rhythms and such. All right? So what is the rate for number 1, top left there? So notice that the QRS complex lines up nicely with a big solid line there, right? So if we go out and we look at this guy here, okay? So we got a solid line right there, right? The next solid line, you might have to cross your eyes, but there's that, if the R wave was right there, heart rate's 300. But that's 300, 150, 100, heart rate equals 75. It lined up perfectly. That's nice, right? Next one, you don't have doesn't line up in a big box, but it does it's still a regular or irregular rhythm. That's a regular rhythm. So I could kind of approximate, it's like the halfway point of the box. So if a heart rate was right here, it'd be 300, 150, what's next? 100, what's next? 75, what's next? 60, heart rate 60, that's borderline. It could be bradycardia, it could be just on the cusp. We'll continue to monitor, right? So heart rate is 60 for that one. So all we're doing is calculating the rate. We're not interpreting the rhythm right now, right? Next one, regular or irregular? That's an irregular rhythm. Why is it irregular? How do I know that? So to know something's irregular, the R to R intervals are different, right? So what's an R to R interval? It's the distance between here and here, here and here, here and here, here and here, right? So if I look at this one and this one, if I were to measure that, I got my calipers out, I spent the extra 20 bucks on NS 101, I bought my calipers, then I could pull it out and I could say, look, it is even, right? It's the same number every time. But you can kind of eyeball that for number 3, right? You can see that is not even between here and here, right? Those are different, yes? Right, so this R to R interval and that R to R interval will do 300, 150, I'm going to get different numbers each time, right? So I just take that 6-second strip, we'll just assume it's 6 seconds, and multiply by what? 10. So how many complexes are there? Heart rate is what? 90. Okay. Next one, irregular or regular? There's extra space there. If I cross my eyes and close one eye, it looks like a little bit of extra space there, right? So it might be just a PAC or something, which it looks like it is. But if it's irregular, let's just assume it's irregular. What do I got? 1, 2, 3, 4, 5, 6, right? So heart rate is what? 60. Okay. Next one, definitely has some irregularity there. So you've got this little run of SVT at the front, and then we're back to our normal rhythm there. I mean, you can measure the heart rate for the normal rhythm, and you can measure the heart rate for the fast rhythm, because the fast rhythm looks a little bit regular. But let's just assume the whole thing is irregular, right? So how many complexes do we have in that 6-second strip? 14. What's the heart rate? 140. Okay. Top right. What do we got? Is that irregular or regular? That's an irregular rhythm. That's a 6-second strip, we'll assume, right? And then what's the heart rate? 17 complexes times 10 is 170 is the heart rate. Okay. And then next one, number 7, irregular or regular? That's an irregular rhythm. So is that, how many complexes we got there? 6. So heart rate is 60. Okay. Next one, regular or irregular? That's a regular rhythm. So that means we have to use what method? 300. So 300, 150, 100. 75 is between 75 and 100. It's halfway, so therefore it's probably 92. I don't know, right? Let's say 92. Right? That's my heart rate. We know it, but if it's a sinus rhythm, spoiler, so we know it's either sinus rhythm, sinus brady, or sinus tach, So what is it? It's sinus rhythm with a heart rate of approximately 92, right? Next one looks a little bit faster, so it's probably a sinus tach, but how fast is it? Is it like upwards of 150 where I'm concerned that they could be at risk for some hemodynamic compromise, or is it maybe a little bit stable? All right, so this guy lines up with nicely, right? So what's the next box? If there was a QRS complex right there, heart rate's 300. If there's a QRS complex right here, heart rate is 150. If there's a QRS complex right there, heart rate is 100. So the heart rate is between 100 and 150, about halfway, about 127. All right?
On the 300, we're only counting the dark lines, correct?
Dark lines, yeah. I mean, you can do the other thing where you just count the small boxes and divide it into 1500, but then you have to use a calculator. That takes time. All right? You have 1.2 minutes for each question. All right, number 10. What is the sequence? What is the social security number for EKGs? What is it? B. All right. I mean, you can go further. I think it goes like a 35 next, but really, once you're less than 50, you know what you got. Okay. And number 11. 3.5 beats in a 6-second strip. And let's say it's an irregular rhythm. So what's the heart rate? B, 35, right? 3.5 beats in that 6-second strip times 10 is 35. What's the width of each small box? Not 0.40, but 0.04. Okay. And number 13. 5 beats in an irregular rhythm, right? So 5 beats equals 5 times 300? No, 5 times 10, right, is 50. Well, I circled both, I guess. All right, so C. And then 14. Big boxes are 0.20 seconds, all right? But they've got 2 options for 0.20, so which one is it? A. A big box goes 5 boxes up and 5 boxes across. Otherwise, it's not a box, right? It'd be a rectangle. And then distance of 2 big boxes and 2 little boxes is what? So 2 big boxes means I have 10 small boxes, right? There's 5 small boxes per big box. So what is it? C. 0.48. Does that equate? So how much is a small box? 0.04, right? So 0.04 times 12, right? What's 12 times 4? 48, 0.48. Okay. Makes sense for rates? Any questions on rates? All right, so the first thing is it irregular or regular? And then you look at the strip and see what you got. That's going to tell you if you have irregular or regular. And then you either multiply by 10 or you use the 300 method, right? Which one do you use the 300 method for? For regular rhythms, right? In irregular rhythms, you count the number of complexes and you multiply by what? By 10. Any questions? All right, so the complex itself, so talk about the intervals that are present, okay? So again, how do you measure rhythm, intervals? They're from where to where? They're from isoelectric, not the Q, but the right before the Q, to the isoelectric over here. QT interval is right there, right? QT can be funky because people won't put it before the T wave, it's just after. I don't have a good mnemonic for that, but we only know once the ventricles have officially completed, and that's when the T wave is officially finished, right? And we have the PR interval, which is what? Isoelectric, not the top of the P wave, not the beginning, not the end of the P wave, but before the P wave even lifts off, right? So isoelectric to isoelectric. So we're measuring PR interval. So that is an important, PR interval. Important interval that will let us know if we have a bundle branch or an AV block.
Isn't that P to Q basically?
It is. It's a misnomer. It's technically to the end of the R, technically. Yeah. So in some, I should probably rephrase that. It's probably some QRS complex could be QRS. They could be RS. They could be S. They could be Q. There's all kinds of different QRS complex flavors out there. So yeah, it should, sometimes there's not even a Q wave on certain QRS complexes. So yeah, it is a little bit finicky. But yeah, it's to the start of the QRS complex. and it's not the halfway through, it's isoelectric to isoelectric, just before it lifts off or just before it goes down for Q wave, for instance. Okay, and then R to R interval we talked about. R to R interval is to measure what? What's the whole purpose of R to R? The only purpose of R to R is to assess irregularity and also assess heart rate. Okay. All right, and we talked about the size of the boxes and such as well. All right, so R to R and P to P intervals. All right, so the R to R interval, you can do the math. You can just do 60, it all equates down to 60 divided by the R to R interval. And that'll get you to the right heart rate, the exact heart rate. But what we want to know is figure out, is it tachy or Brady, basically. And that's what the 300 method will help you. And also the multiplied by 10 if it's irregular will help you. Okay. So the whole purpose of the R to R interval is to let you know if you have a fast rhythm or not, right? Also tell you if you have a irregular rhythm or not, right? Because if the R to R is different or same, will you have an irregular rhythm? When you have a regular rhythm, what did I just say? If you have an irregular rhythm, what will the R to R interval be? Different or same? Be different, right? All right, so then that's really the only purpose. I mean, if you have your calipers that you bought, right, for 20 bucks, go for it, right? Otherwise, all you can just fold over the paper and use the poor man's calipers. You just measure the R to R and just kind of slide your paper to the side and see if they march out, see if they are equal, right? If they're not equal, that means the R to R intervals are different, therefore I have an irregular rhythm, right? So who's the poor man? That's us, all right? So what else? P to P interval. P to P intervals is just the atrial rate. So really we were calculating technically the ventricular rate. And people with sinus rhythms, they have the P and the QRSs match, right? P wave, QRS, P wave, QRS. But some people don't always have that luxury, right? Some people have P wave, nothing. Then P wave, QRS, then P wave, nothing. So they have dropped QRSs. So one of the ways we can see if someone has a irregular rhythm is that fashion, but also there's what's known as AV dissociation, where the atria are doing their own thing compared to the ventricles. The ventricles are contracted at their own beat of their own drum, literally, and the atria are doing their own thing. They are literally divorced, right? They're doing their own thing, so like when you have ventricular tachycardia, your ventricles have taken over, right, and they are tacking away ventricular style, which is wide QRS complex style, right? They're tacking away, and you can even just kind of find some P waves hidden in there, doing their own thing, right? That's called AV dissociation. So VTAC is a good reason to compare. So if you look, the reason to measure a P to P interval, sometimes it's obvious, but other times you can, like this one right here, if I measure the P to P interval, why is my P buried in that T wave? That means it was doing its own thing, right? It wasn't P, QRS, P, QRS. The P wave is doing its own thing, and the QRS is doing its own thing. Let me do that different color. Here's the QRS doing its own thing, right? So that's the QRS doing its own thing. That marches out, and my P waves march out too. The P to P and the R to R are different. So that's a way to assess for AV dissociation. And sometimes you'll see when the P wave is like that, when it has when it's marched out, it's like, well, there's no P wave right there, but you can see it bumped up that T wave a little bit. It added some positivity to it. Okay, so it's a way to identify third-degree heart blocks, which we'll learn about later today. Okay, and VTAC, we're not really going to differentiate that here or even in nursing school, but there is technically AV dissociation. The VTAC is doing its own thing, right? All right, so yeah, so measurement of atrial rate. So AFib, can you measure P to P interval? AFib, as we'll learn, has no P waves. It has fibrillatory waves, right? But you can measure an A flutter. Technically, yes, those are F waves, but A flutter, you can measure how fast the atria are beating, right? And why is that worrisome, or why is that needed if I measure flutter waves? If I measure the P to P, like it's really, really narrow. I'm trying to see if I have an example here. I don't have an example of A flutter. Maybe next time I'll put an example A flutter. But I'll point it out later when we talk about A flutter. It has little flutter waves, like 3 P waves before every QRS. And those 3 P waves, if I measure them, they could be like 300 or 280, right? Now, if the AV node is not suppressed, it's going to let every single one of those through. And that's a problem, all right? That's going to cause the heart to beat too fast, and you can get a low blood pressure out of that, okay? So that's the idea behind measuring R to R interval and the P to P interval. Okay, so P waves and T waves, we're really not going to focus on because that's going to be more 12 lead area, and that's really after nursing school. But what you got to know for P waves is that every P wave should be followed by a QRS complex, right? Every time there's a P wave, there should be a QRS complex. If there's not, they could be divorced, right? That means they have a third degree AV block usually, okay? And then there are different P wave alternatives. They churn into fibrillatory waves or flutter waves when we talk about AFib, A-flutter, right? And you cannot get a PR interval when you have those guys, right? So oftentimes we get EKGs turned in with the mini care plans and clinical worksheets, and they say the PR interval is 0.12. It's like, how'd you get that? You can't get a PR interval with AFib or A-flutter, okay? What else? There are morphology things we can point out in clinics. Like, oh, look, they have COPD. Look at that P wave, right? And you can say, oh, look, they have mitral valve stenosis. Look at that P wave, right? You can pick up those things on P waves. P waves should be symmetric, right? They should not be abnormal. If they're abnormal, they might have a disease or disorder. T waves, they are asymmetric. If they are symmetrical, that's a problem, okay? So T waves, they should never be inverted. That's a problem. You should never have inverted T waves. They should not be symmetrical, like I mentioned. They should not be peaked. If you have peaked T waves, that's usually an indication of what? Of high potassium, right? If they're peaked and wide, it's a sign of an MI, technically, okay? So negative, they should not be negative T waves, right? There are a few exceptions, but that's the idea behind P waves and T waves. All right, so the PRI, the PR interval. You have to know the normal, all right? 0.12 to 0.20. I might as well say 0.10 or 0.08 because it doesn't matter if it's low. It only matters if it is high. If it's greater than 0.20, that means it's taking a lot longer to get all these impulses through to the ventricles, because the ventricles are the QRS complex, right? So that means there's something going on with the AV node. It's suppressed in some fashion. Why is it suppressed? What are some reasons you can think of? Someone's taking too many medications that are suppressed in their AV node, right? What's an example of medication that suppressed the AV node? What's that? Digoxin, I heard. Digoxin. All right. So digoxin affects the
contractility and heart rate.
Contractility and heart rate. I don't have an extra cookie for you, sorry. All right, so yeah, so AV node is going to be, let me know if it's good, I bought it. So I told them make me some cookies for my students. Oh, how old are they? I need letter-shaped cookies for my EKG lecture. All right, so anyways, PR interval should be great. If it's greater than 0.20, there's a problem there, right? And you measure PR intervals from where? Isoelectric to isoelectric, okay? So it's the start of the QRS and it's before the P wave. So P, look at this P wave right here, that PR interval. That is ridiculous, right? So when you have ridiculous PR intervals, that's usually a sign of a third degree AV block. So we'll talk about that when we talk about AV blocks, okay? So short, that could be, we're not going to focus on short right now, but long, that means we have an AV block of some sort, right? So longer, longer, longer. We'll talk about those with AV blocks. That's usually a second degree type 1. So we'll talk about all these degrees and types at the end of the lecture today. All right, so hold AV blockading agents. What is an AV blockading agent? Digoxin, all right. What else? Verapamil. What's verapamil? Non-DHP calcium channel blocker. There you go. All right, so we got non-DHP calcium channel blockers such as verapamil. If someone has verapamil on board and you got the PR interval of 0.28, it's like, well, shoot, I should probably hold this medication, right? And whenever you hold the medication, you have to let the doctor know what you're doing. You can't just go be like a cowboy. It's like, no, I'm not gonna give this medication. You have to be. It's sus. So when it's sus, you have to let somebody know, right? You say, I'm gonna hold this medication and notify the doctor and see do they still want to give it. And also you need to there should be parameters on a lot of these medications. They should say hold for heart rate less than 50 and hold for a PR interval greater than what? 0.20. Usually they do like 0.24. Like they'll allow a little bit of risk versus benefit kind of thing. The benefits outweigh the risk, right? So their cabinets don't get made inappropriately, right? It's like I will allow up to 0.24. But as far as we're concerned when it's greater than 0.20. Okay? So that's the key takeaway with PR intervals. And we'll come back to the other pieces when we talk about AV blocks. All right, so the QT interval. So the QT interval is completion of repolarization of the ventricles. If it is prolonged, it can lead to torsades, right? So QT is super prolonged here. We can lead to torsades de points. And we'll talk about torsades when we talk about ventricular rhythms, but It's important to measure the QT because why is that important? If it's prolonged, I'm at risk for this lethal rhythm, and that's not good. So it's our responsibility to know what the QT interval is before we give medication, for instance, that might prolong it. Or if I notice the QT interval is prolonged, I say, hey, what's the potassium or what's the magnesium? Because that could be prolonging my QT interval, right? So electrolytes are an important thing that prolong the QT. Just being bradycardic itself can prolong the QT, but drugs are things that will prolong the QT. A lot of drugs, like almost every drug has a little bit of QT prolongation, but the drugs we have to pay attention to are down here, right? Are the ones that are going to prolong the QT. And notice amiodarone is on that list, right? So amiodarone is a significant reason that our QT can be prolonged, okay? You'll learn about antipsychotics in psych. You'll learn about antibiotics in MedSurg 2. Antiemetics, I think we'll touch on a little bit, but someone's getting nausea medication, someone's getting antibiotics, someone's getting antipsychotics. That's a good question for your clinical instructor to ask you. Hey, if your patient's on the monitor, what's the EKG, right? The QT is 0.52. Well, is that bad? Should I hold the medication? You probably should. And you should let somebody know about it, right? Now, the caveat with QT intervals is the QT interval is always going to be longer or shorter whether your heart rate's higher or lower. If your heart rate's low, your QT is guaranteed to be prolonged because it's going to take a long time before each beat. Same thing that QT is, in tachycardia, the QT is never going to be greater than 0.45 because what is 0.45? 0.45 seconds, right? So if you do 60 divided by 0.45, that's like 110 or something. It's always going to be less than that, right? So QTC is corrected for heart rate. So there's a little formula here. You just go to MD Calc and you just punch in the numbers. All you got to punch in is the QT and the R to R. And you have to have an R to R interval, which corrects it for rate, which R to R is for rate, right? And you have your QT that you measured. You punch those in and you get a number. Usually on most 12 leads and most of the monitor, I think both hospitals use the same monitor system. The GE monitor, it tells you the QTC also, as long as you punch in the R to R, all right? So you punch those numbers in, it will tell you the QTC. So the QTC is immensely more important than the QT, all right? So why is that? What's the purpose of QTC? It is corrected for heart rate. If someone's heart rate is 60, you can trust that the QT and the QTC are the same. That's how the math works out. But if it's anything but heart rate is 60, you have to do QTC, and that will tell you if it's prolonged or not, right? And what is a prolonged QTC? Greater than 0.45, right? So if it's QTC is 0.62, and someone's about to get their dose of Levaquin right here, what's the concern? They could have a major adverse cardiac event or a MACE, right? We talk about diabetes medications. Some of them cause MACEs. What's the major adverse cardiac event? Torsades, right? So that's a problem when you're just give medications just left and right. You don't realize that they could be at risk for a lethal rhythm, right? And cardiac arrest. Okay, and if they also have a hypomagnesemia and a hypokalemia and a QTC of 0.62, and they're getting amiodarone and an antiemetic, and they're getting Levaquin, and they're getting all these things all together, all these are additive. It's not like one or the other. They all are going to add on top of each other, and they're high risk of torsades in that case. All right, so the ST segment, you're going to focus on that more in MedSurg 3. That's where you look to see, well, the ST segment's elevated. I might have a ST segment elevation myocardial infarction, or a STEMI, right? And then you have N-STEMIs as well, which is just where the ST segment is not elevated. It's just depressed, right? Or the T wave might be inverted too. So those are called STEs, right? ST elevations, or STDs, ST depression, okay? So when you look at the ST segment, sometimes if it's not isoelectric, right? It's up or down. That is a sign that there might be some heart attack happening, right? There's other reasons, but the most worrisome thing is that there might be a heart issue happening. Okay, so sometimes EKGs are only like 60% accurate. So when someone comes with a heart attack and they say, "Oh, I put them on the EKG and EKG showed nothing," well, they're only 60% accurate. That's only a little bit better than a coin flip, right? So it could be really looking at the symptoms is the most important piece. You'll learn about the symptoms more in MedSurg 3. I think we'll touch on it for exam 2, because your patient can have a complication of acute coronary syndrome if they have CHF or the like. Okay, so the priority if someone has chest pain is to get a 12 lead to confirm. And even then, if they still have chest pain, it could still be a heart attack. Okay, so ST elevation depression is just at the ST segment, which is isoelectric to isoelectric. If that's depressed or elevated, that's a sign of it could be a sign of a heart attack. All right, so the QRS, so it's 0.08 to 0.12. Really don't care if it's less than 0.08. What we care about is if it is longer than 0.12. And some people might argue and push up their glasses and say, well, 0.10 to 0.12 is also concerning. That's a sign of ventricular delay. But really, greater than 0.12 is where we are concerned, right? That means the QRS is getting bigger and bigger and bigger. That means it's taking longer and longer time to get through the 405 and 5 freeways here, right? Either there's a bundle branch block or there is something that's depolarizing and causing a wide complex, such as a ventricular tachycardia, like a PVC or a VTach, that's causing a abnormal conduction through the heart, okay? And yes, the QRS has different morphologies. They can be just an R wave, like I mentioned, just an S wave, just a Q wave, just a QR, just a RS. There are different variations. I'm not going to test you on that. There are different ways to figure it out, right? But it's not always going to be textbook Q first, then R, then an S, right? They can have differentiating looks to them, okay? So more important is it wide? Because if it's wide, that means that it could be ventricular. Okay, it could be ventricular in origin. Now the caveat here is that if it's narrow, that means it's always coming from the atria, 100%. There's no way that it came from the ventricles if it is narrow. Okay, but what if you have an SVT or you have a really fast heart rate up top, right? A really fast heart rate up top, and it's going through the ventricles really fast, and they have a bundle branch block. Well, that's going to be wide, isn't it? So there is, that when someone has a wide complex tachycardia, it could be atrial or supraventricular, or it could be ventricular. Okay, so atria, if it came from the atria, QRS is always what? Narrow or wide? Always narrow, no matter what, right? If it's wide, if it's narrow, it's always coming from the atria. But sometimes you could have AV node problems, you could have conduction delays, you could have bundle branch blocks, and sometimes it can come from the atria. So when you have a wide complex, it's either or. It's either atrial rhythm or ventricular rhythm. You have to do a 12 lead, you have to consult a cardiologist to make sure it's not something, to figure out what it is and what medication they might be on. And again, that's not something we're going to have you differentiate, like looking at a 12 lead and looking at these things. But what is important is that if they have a wide complex, a wide QRS greater than how much? 0.12, and it's tachy, which is like greater than 100, especially if it's greater than 150, we are really concerned that they could be having VTach, right? It's not our job to figure out, oh, they could have a SVT with a bundle branch block and this and that. That's really, we have to report that. That is critical, that we know that wide complex tachycardias could possibly be VTach. And VTach is one of our lethal rhythms, which we'll be going over. Okay? All right, so that is the idea behind QRSs, P waves, PR intervals, all these things, right? And again, a lot of this came from physiology, so we're recapping a lot of things here, okay? And then the next thing that you have to know about is what does that mean and what do I do about it? So what are the nurse interventions I do for this? Like get a 12 lead is usually the right answer, right? I'm going to get a 12 lead to figure out what exactly am I seeing, and assessing their blood pressure, because if a rhythm is going off, it might be affecting the blood pressure. Right. My next thing is to, again, notify provider. But next thing is like, well, shoot, what's the magnesium level? Because my QT is prolonged. What medications might they be getting because the QT is prolonged? Or if the PR interval is prolonged, what medications might they be getting? Yes.
How do you interpret the rhythm at the bottom right?
Bottom right, it's by Gemini. It's a PAC by Gemini. So you got actually it looks a little bit PVC, but it's a rhythm that's ectopic. It's happening before it should, right? It's happening out of nowhere. Like their intrinsic rhythm, like their underlying rhythm, what they have normally is this guy right here, which comes from the atria, so it's narrow, right? And then they have little PVCs or PACs. We'd have to look a little closer, and I'd have to see if there's like P waves there, which looks like they're Not really. The T wave's okay. Okay.
Would that be what you were talking about with the going into like a torsades, if that was just over a little bit?
Exactly. Yeah, I think that's what I was kind of going for here. But yeah, if this was right on top of that T wave, then you can be at risk for torsades, right? That's another important risk cause of torsades. If someone comes in with torsades, he's like, well, why'd they go into torsades? Or like you're getting a report in the morning and the nurse says, oh, they had episode of torsades overnight. It's like, well, shoot, there's like 3 or 4 things I gotta look at. It's like, first, do they have like a lot of PVCs? That might be the reason. Next thing is what medications might they be getting? And the next thing is what electrolytes do they have? Yes. Yeah, like that could definitely be high risk for that. This over here is a supraventricular tachycardia. It's narrow. No way it's a VTach, 100% no. But over here, this could be ventricular or it could be atrial. We really can't tell until we get a 12 lead and we look a little bit closer. Okay? But if that was fast, right, how fast is that? This guy lines up with a nice line right there, right? 300, 150, 100, it's like 125, 130. So that is a wide complex tachycardia. That requires expert consultation. That means you notify a provider so they can look at it and they look at the patient too, see how they're looking, and they might require medication, right? If that is indeed come from the ventricles, which is probably not because there's P waves before the QRS complex, then if it was like a ventricular tachycardia, we can give medication for it, right? What medication you can give for ventricular tachycardias? Adenosine is for SVTs. Amiodarone. Who's at amiodarone? All right. Luke gets a cookie. All right. So yeah, so that's the idea behind these rhythms and the intervals. The importance of the intervals is understanding what, recognizing it, interpreting the information, analyzing the information that's in front of you, and then what do I do about it? What are the possible causes? What are the possible complications? What are my nursing interventions I do for it, right? All right, so we'll finish this little section on artifacts, and then we'll take another break. All right, so things that are not arrhythmias. So before we get into arrhythmias, where we talk about atrial rhythms and sinus rhythms and ventricular rhythms and AV blocks, we're talking about things that are not rhythms, right? Things that are not rhythms, if you can't figure it out, it might be artifact. All right, and what is artifact? It's things that are interrupting your EKG interpretation, such as this guy right here. It's like, is that AFib or are they just brushing their teeth, right? This right here, there's some respiratory variation on it. They're breathing up and down. The leads are on the belly instead of on the rib cage, right? So non-arrhythmias are things that you really can't figure out. Like, what is this? I don't know. Okay, so to avoid artifact, the thing you can do is make sure your leads are placed correctly, right? So limb leads, there are other different leads, like precordial leads, or when you're talking about 12 lead EKGs, there's some extra leads you can throw in the chest, but usually in the hospital setting, we'll just throw 2 out of those 6, right? So there are different leads that need to be placed on the chest. Limb leads are your white, your green, your red, and your black leads. So you got black, you got red, you got green, you got white. Those are your limb leads. As long as they're 8 centimeters from the heart, you're fine. That is all it requires to get an accurate EKG. Right? If you're right on top of the heart, it's not going to be correct because it's measuring movement of vertices and all kinds of other fancy physics to get you a good readout on your EKG. Some people put it like on the wrist and the ankle. It's like, okay, you're an overachiever. But all you have to do is 8 centimeters, right? It just needs to be 8 centimeters from the heart. That's all you need. And avoid bony prominence, right? Because electricity does not conduct well through bone, right? It does great through water. We're made most of it 70, 80% water, right? So 8 centimeters from the heart. And then also hairy chests are not okay, right? You can't be having hairy chests. That's not going to have good limb contact. You have to be good contact with the skin. And when it contacts with the skin, you usually want to scrub with alcohol, and also you mentioned like scoring the patient. I was like, that seems a little bit extreme. Alcohol is good enough, right? And no hair. And when you cut hair off someone's chest, how do you document that? Clipped, right? Why don't you document shaved? It would open the skin up. It's a closer shave, and if a surveyor comes in, they're going to say, "Oh, you shaved the chest? That you're putting at risk for infection at that point." So clipping is the proper terminology there. Okay. So what else? So we got our limb leads, right? And how do you know which one goes where? There's a little cute mnemonic here, right? White on right, smoke over fire, right? And the green one is always the ground lead. So like when you look at a electrical socket here, or the ones that are not in the holes in the ground right there, there should be a third hole, and that third hole is the grounding pin, and that prevents the electricity from just going haywire, right? So usually when you have artifact, the first thing you should look at is the green lead attached, right? If it's not, it's probably the reason, okay? So that's the idea with your limb leads. And then we have two little brown leads for our usual boxes that are on the patient, and they usually are in on either side of the rib cage, or sorry, of the sternum. Okay. There are different locations. We're not going to focus on that. It's more 12 lead, where I'm doing a V1 or a V6 or a V4. That's more for 12 leads, which you don't learn in nursing school. Okay. So sometimes you can't figure out what the heck is what, right? Is it P wave or QRS or what's what? You can switch the leads. So you can look at lead 2 or lead 3 or lead V1 or lead V3 or lead AVL. There's different leads out there that you can interpret EKGs in. Just sometimes the QRS might be flipped. That's really the only difference. You should not have T wave inversion, right? Your P wave should always be upright. So that's the idea behind looking at your EKG. It could be the leads are not placed correctly, or we're not in the correct lead. Okay, so different kinds of artifact. All right, so we have like interference. Sorry, they got movement right here. So they're moving along. They're maybe moving in the bed, or it could just be the lead is not tightly attached. Right, it's coming loose. Someone did not clip their hair. Right, so it could be also the wire itself is cracked. Right, going into the box. Like that could be a problem as well. Okay, it's also they could be shivering. So shivering can cause artifact. Seizing can cause artifact. So the key takeaway here, someone has artifact is what? Is check the patient. Check to see if they're okay, right? If you see this on the monitor, you're just like, oh, they're okay. They take the monitor off from time to time. So it could be going in the room and they are asystole, right? And that's happened more than once. I can't tell you the amount of times I've seen that, right? Patient's been transferred from the ER over to the ICU, and then they take all the monitoring equipment off, and they transfer from one bed to the next bed, and they put all the monitoring equipment back on, and it's asystole. It's like, oh, are your leads attached? Yeah, they're attached. You got a pulse? No. So now we're going to CPR, all right? So that's kind of like a transport safety thing, is you always have 2 sets of leads on the patient before you hand off, okay? Anyways, skin prep is key, all right? They're hairy, sweaty, salty people. That can be a problem. Okay, so document shave. You want to make sure you are clipping the hair. And we should be changing the leads at least every 24 hours. That's going to let us, because the little gel contact on the leads can dry up. So we want to make sure it's changed every 24 hours. And as needed, if they are sweaty. Okay. Sometimes there's something called like 60 cycle interference. That's where they are playing with they have a LAN party going on in the room. You walk in the room, it's like, what is going on here? Can't tell you like how a handful of times people brought in their own TV. They got like 2 computers hooked up, and they got their PS5 going. So yeah, we can't be doing this. Dad needs to A, he needs to rest, but also B, this is not we're causing some interference. Okay, so that's the idea. This little green lead is your ground lead. That's one thing you want to check if you have a lot of artifact going on. All right, the 60 cycle interference is when you have other things plugged in. There's a story went to some conference, and the lady was saying everybody was dying in bed 5. Couldn't figure it out. Is because the pacer that they plugged in was shorting every time they plugged it into the wall because the ground lead was not working. Well, that's unfortunate.